This is a very important special session about prevention, the major player in cancer control and the cancer treatment cost saving. I am delighted to announce my co-chairman, Professor Faisal Amir and Professor Ahmed Zawawi. I am Dr. Salah Al-Msidi. The first speaker is Professor Ching Har Yip. She is a professor in University of Kuala Lumpur, Malaysia. And the title is Breast Cancer Prevention, the Middle and the Low-Income Countries.
Thank you very much. Now, I'll be talking about the prevention of breast cancer in low and middle income countries. The incidence of breast cancer is higher in the richer countries compared to the poorer countries. As you can see from this map, the darker colors are the high-income countries with the highest incidence, and the lightest color are those in the poor countries, especially sub-Saharan Africa, with the lowest incidence. I have divided the countries in the world into different sections, and this is the data from GlobalCan 2012, which is, in some countries there is no data, so these are estimates in those countries. And you'll find that the incidence is very high in the countries like North America, Australia, New Zealand, European Union. These are the high-income countries. And then you have South America, which is less. And then MENA, which is Middle East and North Africa, which is what we are going to talk about today. You'll find that it's 43 per 100,000 in MENA. In sub-Saharan Africa is lower, and in Asia is the lowest. I am from Asia, and I will try to explain why in Asia the incidence rates are very low, because this may have implications in the reducing the incidence of breast cancer. Now, I'm in Egypt, I'm from Malaysia. Just comparing the incidence in Egypt and Malaysia, both of us are in high middle income countries, and we are predominantly Muslim country. You find that the age standardized rate in Egypt is 49.5 compared to 38.7 in Malaysia, and these are still a lot lower than the high income countries. Oops, it doesn't move. So even though the incidence is lower in the developing countries, you find that the rate of increase is very high. In the Western countries, the incidence is actually decreasing, while it is still increasing in the Asian countries. Now, the median age at diagnosis of breast cancer in the low and middle income countries is at least 10 years younger than those in the high income countries. However, the age-specific incidence is still higher in the high-income countries. Age-specific incidence is the number per 100,000, which is actually different from the age-standardized rate. So, but you'll find that the difference is less in the younger age groups compared to the older age groups. The main incidence, the main reason for the younger age is because of the younger population in the low and middle-income countries, with a lower median age, as well as the cohort effect. That is, the older women are subject to less risk factors compared to the younger women. Because, I mean, women of my mother's generation, a lot of the risk factors occur actually when you are young, like early menarche, having a lot of children, breastfeeding. These are, these occur in the younger women. So because of the cohort effect and the changes in lifestyle, you will find that increasing generations of women are subject to different risk factors. Okay, so this is just an example of the population pyramid in a developing country compared to a developed country. In my country, the median age is only 27 years old. That means 50% of the population are below 27. So the median age of breast cancer in Malaysia is only 50 years old. Whereas if you look at the developed country, like in UK, the median age is 42 years old. So it's a totally aging population. That's why the age at diagnosis of breast cancer will be higher. Today, cancer is potentially the most preventable and most curable of the major life-threatening diseases. But if you look at all the cancers, under others, which is breast, it's only 10% preventable. Like now for cervical cancer, it's 90% preventable because you have the HPV vaccine. Even liver cancer, the hepatitis B vaccine, because these are cancers where you have a virus. For breast cancer, there's no virus, so you don't know the cause. So it's one of the least preventable cancers. And when you look at the cause, there's no single cause of breast cancer, except if you have a mutation. And since there's no single cause, it's difficult to prevent breast cancer. However, you can reduce the risk by studying what are the risk factors that predispose a woman to develop breast cancer. So these are the factors contributing to a lower incidence of breast cancer in women in LMICs. So there's less exposure to estrogen because traditionally we have a later menarche and an earlier menopause, lower level of obesity, and less hormone replacement therapy. There's lower exposure to other breast cancer risk factors, dietary factors. In Asia, the diet is very soy-based, traditionally lower saturated fat, increased vegetables and fruits. But this may not be the case in Egypt because I noticed that you all eat a lot of meat in the past 2 days that I've been here. And our lifestyle factors: earlier childbearing, more children, longer breastfeeding, less sedentary lifestyle. This was the lifestyle of women, you know, in the low and middle income countries, which is rapidly changing. So a longer exposure to estrogens increased risk. So I've already talked about early menarche, late menopause. Having no children or late first childbirth increases your risk. Taking postmenopausal estrogen replacement therapy and taking oral contraceptives for a long time. So those are reproductive risk factors, some of which is modifiable, but some is not. Now, can diet reduce risk? Diet is always modifiable. Unfortunately, there's no food or diet or supplements that can prevent you from getting breast cancer. Now, does soy reduce your risk of breast cancer? This is still very controversial. Based largely on case control studies, there is a suggestion that soy food intake may have protective effects against breast cancer, and this was believed to be the reason why breast cancer incidence in Asia is lower. Now, the Women's Health Initiative trial were looking at a low-fat diet, and there's no significant differences in breast cancer risk between those who took a lot of who took a low-fat to a normal diet, but there is a suggestion that a low-fat diet may reduce the risk of first-time breast cancer in women whose diets were very high in fat to begin with. Reducing fat, increasing fruits, vegetables, whole grains will ensure your body is getting enough nutrients and contribute to overall health. And also, this sort of diet, you will not make you fat. And obesity is also a risk factor. So, lifestyle, what about exercise? Exercise is physical activity, it's a form of exercise which reduces risk. And this is one of those which is quite evidence-based, that your risk of breast cancer can reduce, your risk of breast cancer can be reduced by exercise. And the American Cancer Society recommend that adults get at least 150 minutes of moderate intensity or 75 minutes of vigorous intensity activity each week, or a combination of these, preferably spread throughout the week. Postmenopausal obesity, and which is a BMI of more than 26, is associated with increased risk. And you can control postmenopausal obesity with diet and exercise. Alcohol also increases the risk of breast cancer. So these are all modifiable risk factors. What about pre-existing benign breast lumps? This is a very small little row, but I thought I'll add it in because there are some types of pre-existing breast lumps which may turn into cancer, so removing them would prevent breast cancer, but these are extremely rare. Probably 99% of benign breast lumps will never turn into cancer, but the risk is higher with atypical ductal hyperplasia or atypical lobular hyperplasia. Now we come to this term, westernizing women's risk, and this is a paper written by Peggy Porter, and the term westernization encompasses generally desirable changes. That means socio-economic improvements that increase life expectancy and allow women reproductive control, as well as the adoption of less desirable habits, dietary changes, lifestyle changes such as decreased exercise, all which could increase breast cancer risk. But of course, as we develop, women can exert control over their reproductive life. As a woman, I'm not going to get married early and have 10 children and breastfeed them all because I want to go out and work and have a career. Now, breast cancer incidence increase from areas of low to high breast cancer with migration from areas of low to high breast cancer incidence. And this is just another thing that shows that environment factors, lifestyle and diet will have an incident, will affect your risk of getting breast cancer. Now, the age and menarche is decreasing in Asian countries. I'm sure you may also see it here. Women used to have menarche at 15 years old, and now you find that even at 11, 12 years old, they are starting their periods. And this would increase your risk of getting breast cancer. So these are summary for breast cancer risk factors, some modifiable, some not modifiable, which I have talked about. So that's primary prevention. And how do we prevent breast cancer? Because risk factors, some of them are not modifiable and some are modifiable, but the only way to prevent breast cancer is actually to remove both your breasts. But when is risk considered so high that we resort to this drastic measure? The only thing is genetic mutations, BRCA1 and BRCA2. However, this accounts for only 5 to 10% of all breast cancers. So 90% of breast cancers are not due to a genetic mutation. And doing genetic testing counseling became very, very popular with Angelina Jolie coming out with her status of BRCA1 and undergoing risk-reducing mastectomy and bilateral salpingo oophorectomy. Now, chemo prevention, tamoxifen and raloxifene can reduce the risk of breast cancer. However, the side effects would make it not very popular. And there are 2 trials done which show that tamoxifen and raloxifene do reduce your risk of breast cancer. And the aromatase inhibitors, with their trials done also, which also reduce your risk of breast cancer. And these are the aromatase inhibitors which also reduce estrogen levels. But the uptake of tamoxifen or raloxifene is very low because of the potentially serious side effects. Because if you're giving it to a healthy woman, you might cause her to have problems that she wouldn't develop. So the dilemma is it possible for developing countries to progress economically and socially, at the same time retain the lifestyle and diet which has kept the incidence of breast cancer lower than in the Western countries? And is the increase in breast cancer incidence too high a price to pay for economic development? I'll leave you this now. Since primary prevention is not so successful, what about secondary prevention, which is early detection and screening of breast cancer? Now, secondary prevention screening is a very sensitive issue because there's a lot of anti-mammogram, a lot of pro-mammogram people around. So I will not want to go into all the controversies regarding mammogram screening. Now, in low and middle income countries, we don't really talk about screening for asymptomatic disease. We're going to talk about downstaging of symptomatic disease because a lot of women, I've done the median size, which actually look at the median size. In my country, the median size of a tumor is 3 centimeters. So you don't really need mammogram to look for a 3-centimeter tumor. And also, in most LMICs, there are actually no national population-based programs for early detection of breast cancer. But if we do set up a program, the first thing is to make sure that you develop manpower and treatment facilities, which unfortunately may be also lacking in most LMICs. Now, why do women present late? This is a study done by my colleague in Malaysia. Fatalism is a major problem, and cancer fatalism, actually there is a tool to measure it, you know. So women deny, there's denial, avoidance, and they say that it's God's will, why should I fight it? Believe in alternative therapy as an active form of treatment and a more acceptable option of treatment, because in most of the low and middle income countries, there's quite a lot of traditional practitioners. And decision-making, there's a lack of individualistic and autonomous decision-making, with women playing the role of the dutiful wife and daughter. And women actually need sanctioning to see a doctor. Because when I see a woman with breast cancer, I have to decide who's the decision-maker in the family, because normally you have to talk to the whole family, not just the woman. This is traditional treatment we come across. For Chinese women, you have jaw sticks burns. For Malay women, you have cuts, they make superficial cuts in the breast. And I just show this to show that the barriers to early detection are not poor education or poverty, because this is a highly educated woman who's a lecturer in the local university, and she's been on traditional medicine for 4 years, coming with a huge, huge tumor like this that was, I think, about 8 kilograms or something, I remember, when we finally took it out. So what are the methods for early detection that I'm going to talk about? Mammography, breast self-examination, and clinical breast examination, also known as the health worker breast examination. Please note that ultrasound is not an evidence-based method. So screening mammography is the most studied modality, and all the studies done in the West, not in low and middle income countries, have shown almost 30% reduction in mortality. But in low and middle income countries, there's inadequate resources. There's also cooperation of the women themselves. To do a mammogram screening program, you must have a high uptake from women. Even in Singapore, which is a high-income country, educated population, only 45% of women invited for screening actually came for screening. And in UK, a pickup rate of 6 to 7 per women screen, and it's probably lower in developing countries where the incidence is lower. This is an audit. In Malaysia, we only have opportunistic mammogram screening program. So these are women who will just come and say, I want a mammogram. So if you look at the first column, our cancer detection rate is 0.52, 5 per 1,000. Is it worthwhile to do a screening program to pick up 5 per 1,000? But the DCIS rate was 20%. And if you look at the DCIS rate in the diagnostic mammogram, those are women who present with lumps, the DCIS rate is 2%. So definitely, even in this opportunistic program, you get early detection. Only 10% came with stage 3 and 4 in the opportunistic screening group, compared to 40% of women coming with late stage in the diagnostic mammogram group. But you find that the mastectomy rate is the same in both groups. That's something we can't explain, but I have no time to discuss why, but we have an idea why. Now, breast self-examination is not encouraged in countries where population-based screening mammogram programs are available because of the high number of false positives and negatives. But in LMICs, if a woman does not touch her breast, she doesn't see a doctor, how can she feel a lump? So we still actually encourage it. The Shanghai study on BSC, which we all know, showed no difference in mortality rate from breast cancer between the screened and the unscreened group. So this is a RCT, which is level 1 evidence that BSE will not reduce mortality from breast cancer. So what we need to do is to say that we should change our clinical practice. We educate women about the signs of breast cancer rather than just about breast self-examination. We teach women to be breast aware. Clinical breast examination is examination by a healthcare worker, but there's also a lot of problems with CBE. The Philippines study showed that they found women with lumps on CBE, but 42% of them refused any further investigations, not even a biopsy, which means that before you actually even do a CBE, you should actually look at the population you're screening. They may not be interested. I'm in Cairo, so I want to say something about Cairo CBE trial, which was published in 2005, and the initial screen was 8 per 1,000, which is very high. But this is a prevalent screen. There were women with palpable lumps, and it dropped to 3 per 1,000 on rescreening, which is more the number that you are likely to find. And if you look at RCTs on clinical breast examination, looking at the study in India, it showed very good, significant downstaging. But up till now, there have been no results on reduction in mortality, which means the evidence is not sufficiently conclusive to justify the recommendation for routine CBE in a population-based screening program. Public education and awareness is very important because you need to teach women that early detection means that you can cure, okay? Saves a woman's life by downsizing and downstaging disease at diagnosis. And we need to look at the barriers to early detection, which we find all the time in LMICs. Now, I was in the panel that looked at prevention of breast cancer in Asians, and this is something like what I think you plan to do. It's very interesting. We had this in the Asian Oncology Summit in 2013. I was doing the breast cancer bit because we also look at 4 other cancers. So these are strategies that we recommended to maintain the traditional practice of breastfeeding for long periods. Okay? Try not to change your diet. Westernization of the traditional Asian diet should be discouraged. For individual women, counseling should include increasing physical activity and balancing energy such that weight remains stable. And alcohol consumption and use of HRT, which is actually never prevalent in Asian women, should be discouraged. Okay? So, now the breast cancer rates are going to increase in LMICs because we are all changing our lifestyles. So it's crucial that women's awareness of their risk and the government's awareness of the importance of early detection and treatment increase at a similar rate. Now, we talk about risk assessment models like Gale model, but does it work in Asians? Because it was developed in Caucasians, so we actually need to develop our own risk assessment model. And we look at, this is for the whole of Asia, you look at the registration programs, you need to monitor changes in the incidence of DCIS and node-positive disease, and probably the size of the lump at presentation, which is easy to measure. And of course, genetic testing and registration of breast and ovarian cancers in Asia. We actually started an Asian BRCA consortium to look into this. So this is what is needed, because in LMICs, there's actually no money for genetic testing either. So CBE is inexpensive, easy to perform, but we need further research on CBE. Okay? And I think that's about the end of my presentation. So I think the conclusion was that
Thank you very much for this elegant and very important presentation.